Well, good afternoon. You know, there's that old saying, you know, time flies when you're having fun. And it is sort of hard to believe that with this meeting, we've hit our first anniversary. That was on, I've been told. November, you know, at my age, you know, time slows down, so I mean, it was yesterday, but it was November 16th, 2012, that we met for our first full meeting. We've been going for 5 years, and we've seen a lot of activities, a lot of progress. I remember well when David took me into what was our corporate headquarters, as we had to fight our way into that building. And then there was, the ceilings were falling down and stuff like that. So there's been progress all around, and I look out over our staff and realize, you know, that we started, we had like 3 or 4 people, and there's been a lot of very good stuff. I was recently in California, like as of last night, and I got a call from a legislative committee in California, and they wanted to know what's going on here in Massachusetts. They heard all these good things, and you know, how could we help them? What should they be doing? I talked about the work of CHIA and the fact that we just know a lot more about how our health system operates and what we've been doing. And you know, the people in the Attorney General's office, they know us well, but this particular aide didn't. I told them to go on the website. So it's been a very interesting, and I want to thank my fellow commissioners for all that's been going on. I particularly want to thank Carol Allen, been a colleague and a friend from the very beginning. And not only her cheery self, but her commitment to what we've been doing is second to none. This, unfortunately, is her last meeting, but I hope we get to see you, Carol. Come on by and let us know what we're doing and what we're doing right and what we're doing wrong. You've been an inspiration to all of us, so thank you very much.
What do I get to say? Yeah, I hope you will indulge me for a few moments of reflection, and forgive me if I lose my composure, which might happen. Serving on the Health Policy Commission has been a great honor and a privilege, an opportunity to learn and to form amazing connections. The Commission has become an important part of my life, and indeed my identity. I may have to teach my husband to call me Commissioner, just to avoid entering into withdrawal. The caliber of the Health Policy Commission staff and the work that they do is extraordinary. David Seltz has shown us that advanced age is not a requisite for wisdom and knowledge. I will miss the insights and the camaraderie of my fellow commissioners enormously. And Stuart, you have always managed to get to the heart of the matter. I've learned very much from you. It's been exciting to watch primary care practices achieve prime PCMH status by incorporating behavioral health screening and services. And it's gratifying that the patient voice will be part of the ACO governance going forward. I'm particularly thrilled that attention is being paid to social determinants of health. Yet in some ways, we're just scratching the surface. Long term, the only way to reduce the rise in healthcare costs is to create a healthier population. I hope the Health Policy Commission will partner with the Department of Public Health to look at root causes of illness and disparities and focus on public health solutions that are in plain sight. For example, we should encourage the legislature to waste no more time in passing the omnibus tobacco bill that would classify electronic nicotine service devices as tobacco, raise the sales age of tobacco products to 21, and forbid sales of tobacco products in pharmacies. And federal dollars for maternal and child home visiting programs should be put to use, particularly in high-risk communities, because lifelong health begins in infancy, or more accurately, before birth. We have supported care for the homeless, but we haven't called for an end to homelessness. Last week at a public health symposium, Commissioner Burrell described a population health information tool that will help us to identify the areas of greatest need. Sometimes I fear that our work resembles that of a man who loses his keys in a dark alley, but looks for them under the lamppost on the road, because that is where the light is. We focus extensively on inpatient hospital costs and readmissions, yet our data shows that outpatient prices are among the main drivers of rising costs. I believe we could focus more on training and utilizing community health workers and engaging local boards of health. We know that the multiplicity of quality metrics and other regulatory requirements are putting a strain on providers and insurers alike, yet we have largely ignored the provider community and especially physician burnout as needing support and remedies. I hope moving forward that HPC will focus on reducing administrative practice burdens and by emphasizing the physician-patient relationship, return the joy of medicine to practice. Perhaps the Health Policy Commission can exert influence to focus more on using real-time data from electronic health records and patient-reported outcomes not just claims data, which is incomplete, often not timely, and heavily influenced by coding or teaching to the test. Tracking digital health data, electronic standardized patient questionnaires, and functional outcomes would give a truer picture of population health and has the potential to improve provider experience as well by freeing up providers to fully engage with their patients. Finally, let's not waste a public health emergency, the opioid crisis. As resources become available, let's use them to develop and improve systems of care accompanying opioid treatments and prevention. Addressing neonatal abstinence syndrome is an opportunity to develop baby-friendly hospitals across the Commonwealth where breastfeeding and rooming in are the norm. Mounting a public health media campaign can help prevent youth initiation of tobacco, alcohol, and marijuana in addition to opioids. Revving up our behavioral health system should be a permanent solution, not just a temporary fix to address this particular crisis. The future of medicine will include areas we've not explored: genomics, epigenetics, the impact of climate change, societal changes, new technologies, and new pharmaceutical products. Medical education and research need to be supported, but I fail to see the logic in paying for them through an insurance mechanism. Perhaps it is too heavy a lift for the Commission to take on a revamping of how health care and health are paid for, but I can dream.
Carol, thank you so much. Again, you've been a wonderful commissioner. If we all live up to the standards you set, I think we will set a high mark. So thank you. Well, as I said, we moved 5 years, and not every aspect of the 5 years do I clearly remember, but there's one part of the beginning of this commission that I remember very well. And I probably shouldn't admit this, but I really didn't read the law carefully before I got the call from the governor's office to be the chair. But then I figured, I better read the law. And I go, oh my God. They're asking us to, I thought, it was going to be simple. All we have to do is control healthcare spending. I figured, okay, I can do that. But the amount of responsibilities and stuff like that. So at that time, we had decided that David was going to be our executive director. And of course, I held him personally responsible for this law. So the two of us and then a few others sat down and says, how are we going to make this work? And I very quickly came, and David agreed, that the only way we were going to make this work was to sort of split the responsibilities and create subcommittees of the commission so that we could hold the in-depth meetings that are required to really do a good job in all the different aspects of what we're all about. And I thought it was a good idea at the time. I didn't realize how good it did, I mean, what you all have done, I didn't do the counting, but David's crack team did, and we've had 150 committee meetings since the beginning of this commission. And the amount of effort that you all have put in, and the amount of effort that the staff, it's sort of allowed the commission itself to sort of function well. But as things change, the responsibility of the commission is changing, and there are a couple of activities now being debated around the state which could change our activities even more, and who knows what they will be. So I think it's about time that we take another look at the committee assignments, who's going to be on them, how many we will have. We're not right at that position yet to do that for a couple of reasons, including the fact that we don't know exactly what our responsibilities will be. But I do hope to come back to you in either December or in early January with a revised list. And for those of you in the audience, who monitor what we do. If you have ideas where we think we should be spending more time with stuff like that, we would welcome your comments as well. So for my fellow commissioners, obviously, I would more than welcome your suggestions. Because it's about, we need to take a hard look at whether we're organized correctly for the next 5 years, as we have been for these 5 years. So we will get back to you again, either in December or in early January. So, okay, with that said, I'm going to turn it over to you, David, just to give us an update on, and then move us into what we're all about for this session.
Great, so a very brief update for myself. One, on behalf of staff, thank Dr. Allen as well for your public service to the commission and everything that you've contributed. And your legacy will certainly live on through some of our programs and our responsibilities, so thank you. I also want to put a shout out. Today is the first day of open enrollment for the Massachusetts Connector. So for everyone in the audience and our board, get the word out to go to the Mass Connector website and shop and enroll in the open enrollment period. And with that as my 2 announcements, I think we can approve some minutes.
Yes, sure. I delayed doing that because I wanted to, I couldn't, I was looking at Carol and it just led me to get right to that. But we do have to officially approve the minutes of September 13th.
So,
Okay, all in favor? Okay, very good. Okay.
So would also just add, we included in the packets as well as on the screen here our proposed calendar for 2018 to get some meetings on the books. Obviously subject to some amount of change, but so that people can start to plan for next year. And we have locked in already our cost trends hearings dates for next year, October 15th and 16th. So mark your calendars, we'll be back again for the cost trends hearings at that time, a little bit later in October. So with that, I think we're ready to begin the agenda with our market performance work.
Very good. Kate, you're gonna take us through where we are?
Absolutely. Actually, I'm going to turn it over to my deputy, Megan Wolf, to quickly review the material change notices we've received.
Can I just add before Megan takes over, just because, Mr. Chairman, you discussed Carol, this table is officially called Types of Transactions Notice, and actually unofficially it's called the Carol Allen table. Because at one of our very early board meetings, as we were discussing these, Carol said, it's impossible to keep track of them all. Can you find some way to display what it is that we're seeing? And so since then, I've actually in my mind entirely called it the Carol Allen table. I hope that I have permission to continue doing that. After you're no longer a commissioner.
I think it would be inappropriate, if not very appropriate, if we start calling it.
Excellent. Done.
Done.
Perfect. So beginning with the Carol Allen table, since 2013, the HPC has received notice of 88 provider transactions, with clinical affiliation as the most frequent, followed closely by physician and hospital affiliations. We currently have 8 notices under review. I think that might be a record. 3 of these were received prior to the last board meeting. The proposed acquisition of the non-hospital-based diagnostic laboratory business of Cape Cod Healthcare by Quest, the proposed acquisition of Reliant Medical Group by Optum Care, and the proposed merger of Care Group Leahy, the parent of Anna Jake's Hospital, along with the related acquisition of Bidco and contracting affiliation with Mount Auburn Cambridge IPA. 5 new notices have been received since September 13th. These include out-of-state acquisitions by Steward of 8 community health systems hospitals and all 18 IASIS hospitals. They also include the proposed joint venture between Shields and Baystate to operate an urgent care clinic, a proposed clinical affiliation between Harrington Memorial and UMass Memorial under which Carrington OBGYN physicians would apply for staff privileges at UMass, and the proposed acquisition of AdCare Hospital of Worcester, a for-profit provider of substance use disorder treatment services, by the national for-profit AAC Healthcare Network. We are working to measure the potential impact of these transactions on healthcare costs, quality, and access in Massachusetts.
I should point out, when I go around the country, which I have been doing more, there's such interest on the part of other states on what we're doing. It's this, along with a few others, that they all have a real keen interest. I think it's fair to say that we are unique in the country in terms of what we do with respect to analyzing affiliations and mergers to look at their potential impact on the Commonwealth, how much we spend, quality of care. So, thank you.
Thank you, Stuart. So we also elected not to proceed to a cost and market impact review for the acquisition of Community Healthcare, a for-profit organization that operates 10 substance use disorder treatment clinics in Massachusetts by Baymark Health Services, a national for-profit provider of opioid addiction treatment services. The parties stated that they do not anticipate any changes to the services that Community Healthcare provides or to its clinical management. And in our preliminary review, we found little potential for changes in prices or shifts in referral patterns. We also did not find evidence of negative impacts on quality or access.
And as we have done in the past, I hope we will continue to monitor, because everyone promises that, and let's hope that they will live up to that promise.
Absolutely. And finally, we also have one active cost and market impact review before us, which we will be discussing momentarily.
So it's been a little bit of time since we last issued a cost and market impact review report. So I wanted to just give a brief reminder to the commissioners as well as the public about that process before I turn it over to my team, Megan Wolf and Sasha Hisrasnov, who oversaw actually a much larger team of folks working on this cost and market impact review to talk about the findings in our preliminary report. So as I'm sure you recall, the trigger for a material change notice moving forward to a cost and market impact review is where we find that there's likely to be a significant impact on healthcare spending or market functioning. To conduct our reviews, we have the ability to receive confidential data and documents from not only parties, but other providers and payers in the market. And we work with a team of expert consultants, actuaries, accountants, care delivery experts, and economists in particular, to create these findings. We then work closely with our board, and then we issue a preliminary report. The parties then have up to 30 days to respond to those findings, and thereafter we issue a final report which can include potential referrals to the Attorney General's office or to other state agencies. I want to just acknowledge the entire team for all of their phenomenal work putting together this report that we are planning, hopefully, to issue with your vote today. So as I mentioned, Megan Wolf and Sasha Hayes-Rusnov, also in particular, Katzen, Rebecca Balder, and Tara Vidal on my team. I also want to acknowledge the work of all of our expert consulting teams, Gorman Actuarial, Bates White Economic Consulting, Health Management Associates, and Friedman Healthcare. And then last but not least, I'd really like to extend our thanks to both the parties and to other market participants, payers and providers who provided data pertinent to this work. So with that, I will turn it over to Sasha Hayes-Rusnov to walk through the findings in our preliminary report before we ask you for your vote.
So first, a few slides on background as a refresher on this transaction. As you know, the proposed transaction is the acquisition of the Foundation for the Massachusetts Scientific Infirmary, including its anchor hospital, the Massachusetts Eye and Ear Infirmary, and its physician group, Massachusetts Eye and Ear Associates, by Partners Healthcare. This proposed acquisition is under our CMIR review. It is also under concurrent review by the Department of Public Health's Termination of Need program. The parties identified several goals for the transaction, including for Mass Pioneer to become the system-wide provider of ophthalmology and otolaryngology services for Partners Healthcare, for Mass Pioneer to utilize existing Partners facilities to expand outpatient services in particular to additional populations, for Mass Pioneer to achieve operating cost savings by utilizing Partners' corporate services. And the parties have also stated that they expect to achieve market competitive rates for Massachusetts Pioneer subsequent to the transaction. A few additional slides of background on the parties. As you know, Partners Healthcare is the largest healthcare system in Massachusetts, $11.7 billion of operating revenue in fiscal year 15, 8 general acute care hospitals in Massachusetts, a network of specialty and post-acute care providers, an insurance carrier, and the largest physician group in the Commonwealth, Partners Community Physicians Organization. As we'll go into in more detail later in the presentation, Partners hospitals and physician groups garner among the highest prices in the Commonwealth, and their participation in commercial limited network products and Medicaid managed care organization products tends to be less frequent than some other hospital providers in the Commonwealth. Massachusetts Pioneer Infirmary is anchored by an acute care hospital that specializes in ophthalmology and otolaryngology. There are 18 Massachusetts Pioneer locations around the Commonwealth, including the main campus with 41 beds, 8 outpatient hospital satellites, and 10 physician office sites. Most of these outpatient sites, it's worth noting, have been established within the past 10 years as Massachusetts Pioneer has continued to expand and see substantial additional volume. Most of Massachusetts Pioneer Infirmary services at their main hospital site are for outpatient services, and they also have their medical group, Mass Pioneer Associates, about 200 specialty physicians, currently no primary care physicians. It's worth noting that MEEA currently contracts through PCPO, the Partners Physician Group, for the 3 largest payers in the Commonwealth, and is considered to be part of the Massachusetts General Physicians Organization, the subgroup of PCPO that covers Mass General Physicians. In addition to the contracting relationship between Partners and Mass Pioneer, they have long-standing clinical relationships. In particular, Mass Pioneer physicians staff MGH's ophthalmology and otolaryngology services, as well as ophthalmology services at Brigham and Women's Hospital. As in all of our CMIR reviews, we categorize our findings into cost and market, quality and care delivery, and access domains. We'll review the baseline state for parties in each of these areas, and then move on to discuss our findings on the potential impacts of the transaction in each area. I'll turn it over to Megan to walk through cost and market.
Thank you, Sasha. As previously mentioned, Partners is the largest healthcare system in the state, with high shares of inpatient, outpatient, and physician services. Mass Pioneer Infirmary provides more outpatient otolaryngology and ophthalmology than any other provider in its service area, which spans most of eastern Massachusetts, but provides a relatively small share of inpatient services. Partners provides some overlapping services with Mass Pioneer, particularly outpatient otolaryngology. As we have described in past reports, Partners has some of the highest hospital and physician prices in the state. Mass Pioneer has substantially lower prices than Partners and is treated by payers as a more efficient provider in tiered and limited network products. We will go over each of these findings in more detail in the coming slides. These tables provide shares of inpatient discharges, outpatient facility visits, and primary care visits statewide. As you can see, Partners has the highest share of these services in the Commonwealth, approximately twice as large for inpatient and outpatient hospital services as the next largest provider, and approximately 50% larger for primary care services as the next largest provider. We examined the specialty services that Mass Eye and Ear Infirmary focuses on and found that Mass Eye and Ear has the largest shares of outpatient otolaryngology and ophthalmology visits in its service area. Partners has the second largest share of outpatient otolaryngology visits, but only a 1% share of outpatient ophthalmology visits. While Partners does not provide many outpatient ophthalmology visits in its own facilities, Partners physicians provide a substantial share of these services in non-Partners facilities, such as freestanding eye surgery centers, and in non-facility settings. This chart shows the party's inpatient and outpatient blended relative price for one payer and is representative of the commercial market generally. Mass Eye and Ear's relative price, seen here on the left, is substantially lower than the prices of Partners hospitals shown in red dots, both the academic medical centers and the community hospitals. Partners hospitals are higher priced than comparators in each geographic region, shown in columns on this chart, with the exception of Cooley Dickinson Hospital, which does not yet contract jointly with Partners. Partners community hospitals in the greater Boston area are also priced very similarly to each other. You can see those here in the three middle columns. And its two academic medical centers, Mass General and Brigham and Women's, are identically priced for this payer. And you can see that they're overlapping circle in the second column from the left. When we compare Partners' inpatient hospital prices to those of Mass Eye and Ear for the three largest payers, we find that Partners' Boston area community hospitals are 11.5% higher priced than Mass Eye and Ear, and MGH is 34.6% higher. When we compare the parties' outpatient prices for Mass Eye and Ear's mix of services, we find that Partners' Boston area community hospital prices are between 6 and 52% higher than Mass Eye and Ear for the three largest payers, and Mass General is 58 to 105% higher than Mass Eye and Ear. As we previously mentioned, Mass Eye and Ear physicians already contract through Partners for the three largest payers. For payers for which Mass Eye and Ear contracts independently, we find that Partners physicians are 23% to 60% higher priced than Mass Eye and Ear physicians. And as we already stated, reflecting Mass Eye and Ear's relative cost efficiency, Mass Eye and Ear Infirmary is often included in limited network plans and in the most efficient tier of tiered network plans.
In our quality examination, as usual, we examined the party's performance on publicly available, well-validated quality metrics, generally falling into the categories of outcome measures and patient experience measures. We also looked at some of the structures that the parties have set up internal to their organizations that are designed to promote high-quality care, including incentive programs and internal measurement and quality reporting systems. We found, as in past reports, that Partners is generally a high-quality provider system, performing equal to or better than the state average on most of the measures that we examined. Fewer of the standard measures that we tend to examine were applicable to Mass Eye and Ear because of its specialty provider status, but on those that were relevant, Mass Eye and Ear also performed well, and particularly well on measures of patient experience. It was also noteworthy that both Partners in Mass Eye and Ear demonstrate notable commitment to high quality of care through their internal structures and quality measurement and reporting systems. In the access domain, we focused on three main areas of access. One being specialty services for which Mass Eye and Ear is the principal or sole provider in the Commonwealth. Second, party hospital participation in Medicaid MCOs and commercial and limited and tiered network products. And the payer mix of patients served by the party's hospitals. We found that Mass Eye and Ear is the principal provider of a relatively small number of uncommon specialty services in its service area, but there are a set of services for which it is the principal and in some cases the sole provider of these services, making it an important access point for that limited set of services. We found that Mass Eye and Ear participates more frequently in Medicaid MCO networks and commercial limited and tiered limited networks than partners hospitals, and tends to be better placed in tiered network products. And that Mass Eye and Ear and most partners hospitals have a higher commercial payer mix and lower Medicaid payer mix relative to comparator hospitals, with the notable exception of North Shore Medical Center, which is a partners hospital and has relatively high Medicaid mix, relatively low commercial mix. Next two slides provide a little more detail on Mass Eye and Ear participation in payer networks. This slide shows participation of Mass Eye and Ear and Partners Hospital participation in commercial limited network products, as well as their tiering in commercial tiered network products. As you can see along the top line, Mass Eye and Ear Infirmary is generally included in limited networks, except for Tufts limited network product, and it tends to be in the most favorable cost-sharing tier of tiered network products. Partners hospitals are generally excluded from limited network products, and the AMCs are typically in the least efficient cost-sharing tier of tiered network products. The cost-sharing tier of partners community hospitals tends to vary across payers. With regard to Medicaid MCO networks, we see again that Mass Eye and Ear tends to be more frequently in network in Medicaid MCOs, and that partners hospitals tend to be excluded or not participate, except for the MCO that partners owns, the neighborhood health plans. With regard to payer mix, this slide shows payer mix for Mass Eye and Ear Infirmary and the Boston area AMCs. This chart is based on gross patient service revenue data from CHIA, which combines both inpatient and outpatient care. As you can see, Mass Eye and Ear has a relatively high proportion of commercial care and relatively smaller proportion of Medicaid care, although it's notable that Mass Eye and Ear's proportion of Medicare patients has been growing in recent years, which is consistent with the party's data provided about the aging Massachusetts population and their need for ophthalmology services in particular.
Our cost and market impact findings are summarized here. As we will go over in the next few slides, we found that the transaction is not likely to substantially increase partners' overall inpatient or outpatient market share. However, it would substantially increase partners' share of outpatient otolaryngology and ophthalmology services. We anticipate that partners would seek substantial hospital rate increases for Mass Eye and Ear Infirmary's main campus and hospital satellites after the acquisition. If partners were to achieve parity between the Mass Eye and Ear's rates and those of partners' hospitals, consistent with past practice, we estimate that healthcare spending would increase by $14.9 million to $55.3 million per year. The lower bound here reflects parity for Mass Eye and Ear with partners' Boston area community hospital rates, and the upper bound reflects parity for Mass Eye and Ear with MGH rates. We also project that as Mass Eye and Ear physicians join partners' contracts for all commercial payers, changes in Mass Eye and Ear's physician rates would increase total medical spending by $5.9 million per year. The parties anticipate that the transaction would lead to operational efficiencies and allow Mass Eye and Ear to avoid certain capital expenditures. However, they have not committed to passing any resulting savings on to payers or consumers. Here we provide
I would
post-trans-
just like to point out, I'm assuming since this is a preliminary report, these are preliminary findings. That's correct. I think we need to qualify that then.
It says key findings, is it the final report?
Absolutely. So that's true of everything in the report, but these are the key findings as laid out in the preliminary report. As I mentioned up top, the parties have up to 30 days to respond. Other providers and market participants may also provide information to us in that time. And certainly, if we find anything new that changes our findings, those are updated in the final report. Thank you for that clarification, Secretary.
Can you clarify something? You indicated that many of the physicians that are in Mass Eye are already contracted. The contracting is done by partners. But then you indicated in this bullet that some of the physicians are not in that. Explain that a little more.
Sure. So it's not about the physicians, it's about the payers with whom they're contracting. So right now, the Mass Eye and Ear Associates physicians are contracting through the Mass General Physician Organization for Blue Cross, Harvard Pilgrim, and Tufts. For all other commercial payers, they contract independently. And so this estimate here would be as those Mass Eye and Ear Associates physicians join partners contracts for the smaller commercial payers. This is the spending estimate that we.
So it is true, interestingly, that the smaller payers are actually paying lower fees currently to the Mass Eye and Ear doctors than our big three.
That's correct. And obviously, 5.9, you see that that's a smaller impact than what we see on the hospital side, reflecting the fact that some of those rates are already being realized in the physician side. Some of the partners' rates are already being obtained by Mass Eye and Ear.
So here we provide post-transaction shares of Mass Eye and Ear Infirmary's inpatient and outpatient specialty services. As you can see in the top chart here, reflecting the fact that Mass Eye and Ear primarily focuses on outpatient services, Mass Eye and Ear Infirmary does not have a substantial share of the specialty inpatient services it provides in its service area at only 3.5%. Partners has a 34% share. Combined, the parties would have a 37.6% share post-transaction. On the outpatient side, the parties have the two highest shares of outpatient otolaryngology facility visits, and their combined share would be 45.2%. For outpatient ophthalmology, Mass Eye and Ear Infirmary has the highest share, and Partners has a 1% share. Their combined share, 35.6%, would substantially increase Partners' share of these services in the market. On this slide are the three categories of spending impacts that we have modeled based on anticipated increases to Mass Eye and Ear's hospital and physician rates as a result of the transaction. On the hospital side, if Partners achieves parity for Mass Eye and Ear Infirmary with the rates of its other hospitals over time, we anticipate the transaction could increase healthcare spending by $14.9 million to $55.3 million per year. As you can see on this chart, the lower estimate, which would bring Mass Eye and Ear Infirmary rates in line with those of Partners' Boston area community hospitals, would represent a 16.5% increase to Mass Eye and Ear's current hospital revenue. And our upper estimate, which would bring Mass Eye and Ear's rates in line with MGH, would represent a 61.3% increase.
Well, I think it's better, but it said hospital spending, but hospital spending includes inpatient and outpatient, correct?
That's correct, but this is just the facility side of hospital spending.
Correct. So just the last question. Since the Senate is considering a bill where they might control or eliminate facility fees, if that were in effect, what would these numbers look like?
Yes.
Can you say, I mean, is there any way to speculate?
I don't think that there is a way to speculate, but I do want to note a couple things. One is that it's our understanding that facility fees would still be permitted for some services in the main campus of the hospital. So obviously that wouldn't change. And then there's a data point that's just an interesting thing to note, which is that Most providers don't specify when they bill, and in the data that we have in the APCD, whether an outpatient visit takes place at the main campus or at a satellite campus. So we actually are unable to examine how many of these outpatient services are out at community facilities versus at the main campus.
Let's, this is quite interesting. I want to play out, one of the things that is impressive, what you were talking about, is that Mass Ioneer is currently in a lot of networks. And one of the reasons they're in there, they're both high quality and lower cost than some of these others, particularly in the services that are provided partners. So if it turns out that this goes through and they are able to raise their rates to either the community hospitals or to the flagship academic, they would become expensive. But it's unclear whether the networks really are going to be able to find serious alternatives, because they would now comprise such a large percentage of the market. Is that at all taken into account in these estimates?
I think you've flagged exactly the right point here, that when you're talking about providers that would have, more than a third to almost half of the market for some of these services, there's a question of whether or not the other providers in the market would actually have capacity to provide all the services if payers dropped partners in Mass Ioneer from their networks. So this is reflected in things that we heard from payers, that they view Mass Ioneer as an important provider to have in network. And so I think it would remain to be seen through those negotiations whether the payers think that they could afford to keep them in network at a higher price level.
I think the short answer is that this is a static calculation.
That's exactly.
That says what would happen if the rates rose to X. It does not have any dynamic issues about, well, would the rates rise higher than X, or would they get tossed out of the networks and the rates would fall? Would not rise as high as X, or it's really this is kind of a counterfactual of just raising rates to the partners.
I think you're also basically just combining current market share. The other issue that comes into play is, as they grow, they can actually increase market share, which is another issue. I'm not sure if you looked at that as well. On the other hand, when you look at all of this, and what could these two institutions do to make this attractive to the state? Is this something that we look at, that we basically communicate with them, and, for example, more participation in Medicaid programs, things of that nature, other than just pricing? And what type of commitment can they make to make this more attractive? Because all I'm seeing here is, boy, this will have a negative impact on the state pricing. What could they do? Do we spend any time looking at that?
So our preliminary report is just laying out the facts and the data, and these are preliminary facts and data. I think that the question you're raising is one that in past transactions, the parties in their response to the preliminary report have occasionally made further commitments around some areas that may raise concern. But I think, Commissioner, the question you're raising is really one I pose back to this board, and one that I think it would be a discussion point as we potentially prepare a final report, and not something for staff to speculate on.
But why would we just wait for them to come back? Why not make it more interactive in terms of highlighting what we believe would be critical to approve something like this?
David, also, isn't that part of the OON review process?
Absolutely.
We need to separate our roles here, what the role of the Health Policy Commission is from the role of the Commonwealth of Massachusetts Department determination process.
Our role is not one of approval or disapproval, and we do not have the authority to approve a transaction with conditions. Our role really is to lay out facts and data and information for the public's consideration. And in some circumstances, and this will be a discussion, potentially refer our findings to other state agencies that may use this information.
But just to come to this for 1 second, I think we should, I personally have a couple of questions I would like to pose to the parties as a result of this. I think that would be a good thing to gather, not in the sense that we will approve or not, but just questions that come to us upon reading this, to which we need an answer in order to decide our view.
I don't know if it's time to collect such questions, but I want to ask something. You began, your very first slide is their goals in the transaction. And did their representations explain why the acquisition is needed to achieve these goals? The last two goals, operating cost savings and market better rates, yes, but if Mass Pioneer is to become a system-wide provider for partners or partners or Mass Pioneer to utilize partners, is it necessary to have this transaction
Begin
to achieve those goals?
Begin to the mic.
I'm sorry, did you hear my question?
So you're jumping ahead a little bit in our presentation.
Sorry.
We did not,
Shut me up, we're late.
it was not clear to us in our review that corporate acquisition was necessary to be the clinical provider across the partners' hospitals, as they are the clinical provider today for the Mass General and for some services with the Brigham. Maybe I would suggest we have a couple more slides to go. We'll get through this and then we can really open it up as a discussion.
All right, so completing the picture on our spending impact projections. On the physician side, we expect that as Mass Pioneer physicians join partners contracts for all commercial payers, the transaction would increase healthcare spending by $5.9 million per year. Unlike for hospital price changes, which would require contract renegotiation, price changes for Mass Pioneer physicians could potentially occur immediately. In total, based on both hospital and physician rate increases, we estimate that the proposed transaction would increase healthcare spending by $20.8 to $61 million per year.
With regard to the aforementioned potential for operational efficiencies, as discussed earlier, Mass Pioneer's outpatient volume has been steadily increasing, and Mass Pioneer anticipates a need for additional operating room space due to the increasing demand for its services. They're expecting, as a result of the transaction, to avoid capital expenditures by using unused operating room time at existing partners' facilities. However, they haven't yet identified which sites they expect to newly deploy Mass Pioneer services at. In addition, they've identified several areas where they expect to achieve operational increases, including integration of administrative and informational technology functions, the sharing of the cost of research activities, and improved borrowing rates for Mass Pioneer in acquiring debt. The parties are expecting substantial savings from the internal efficiencies that would be retained by partners to be used to support Mass Pioneer's clinical and research activities. However, despite the expected financial benefits that the parties are expecting from the transaction, they haven't yet committed to reducing prices, limiting potential rate increases, or otherwise reducing spending for payers and consumers as a result.
Just as a factual question, have the parties given a total estimate of savings that they expect for the firm?
I believe that in documents that they've filed with the OON program, they've provided some numerical projections, but they have also indicated that I don't know that they've attached dollar amounts, and I also believe that they have indicated that they don't expect that what they've provided would be the total extent of the efficiencies that they could realize in the long term.
However, over time, we do believe in a matter of years, we're talking about $20 million or more per year in savings. So not out of line with what we've also modeled on the potential price increase side. So we're talking about a potential savings and a potential price increase, kind of both potentially flowing back to support clinical and research efforts, but not necessarily going back to payers or consumers.
With regard to quality impact, the parties have indicated that they expect the proposed transaction would improve quality by integrating Mass Pioneer into the partner's ACO model, integrating the parties' quality data measurement and reporting programs, and removing certain restrictions on sharing protected health information between the two organizations that are imposed by HIPAA. As discussed in the baseline section, Mass Pioneer already performs quite well on relevant quality measures, and it's unclear to what extent additional integration of Mass Pioneer clinically and in terms of data collection and reporting for those quality measures would actually improve Mass Pioneer's performance on those measures. As we've discussed, the Mass Pioneer physicians are already part of MGPO and thus participate in partners' internal quality and performance incentives. It's therefore unclear how the transaction would change those incentives currently in place. While the parties have, with regard to EHR interoperability, partners in Mass Pioneer both currently use the Epic Health system and the partner's eCare patient gateway. Corporate integration likely would create some administrative efficiencies in terms of managing patient records in the system. However, the potential impact on overall clinical quality is uncertain, given the fact that they are already about as closely integrated as two organizations that are corporately distinct can be. The parties have also proposed some measures of quality and efficiency to measure post-transaction to DPH. However, they haven't provided to us measurement specifications, baseline data, or targets that they intend to achieve, and they have indicated these will be provided post-transaction. We therefore can't evaluate the appropriateness of the measures or the likelihood of achieving any specific improvements. With regard to access impact, the parties have indicated that the proposed transaction would improve patient access by, again, making MEI the partner's system-wide resource for otolaryngology and ophthalmology, meeting a growing demand for these services, and allowing Mass Pioneer to deploy its services to additional partners' facilities, and ensuring that Mass Pioneer can continue to get patient referrals even in the transition to an ACO-focused healthcare system. Given current relations between Mass Pioneer and partners, it's unclear why the proposed merger is necessary for Mass Pioneer to be the partner's system-wide resource, rather than, for example, expanding clinical affiliations or forming joint ventures or other possible combinations, especially given partners' stated need for Mass Pioneer services for its patients. As mentioned, the parties have not yet identified the sites at which Mass Pioneer might expand services as a result of the transaction. Without details on where Mass Pioneer would offer new services, we can't evaluate to what extent Mass Pioneer's already broad geographic presence in Massachusetts will continue to expand. With regard to the possibility that a shift towards an ACO structure in the market right now might starve Mass Pioneer of needed patient referrals, we note that Mass Pioneer's volume, especially in the outpatient space, has grown substantially in recent years, despite the continuing shift to ACOs and risk contracts that has been occurring. And we also note, as discussed earlier, that if Mass Pioneer were to adopt partners' contracting patterns, or if payers began to exclude Mass Pioneer from limited networks or put it in more less efficient cost-sharing tiers as a result of price increases, that that could create barriers for members in those products to accessing care at Mass Eye and Ear.
All right, let me put this in some context and then ask the question. So we have two parts of this big activity. One is the corporate realignment where Partners is buying Mass Eye and Ear and therefore, and the other is the potential increase in rates brought on by the fact that Partners would be negotiating. Now, you've made several comments that they could go ahead and do a lot of these things without having corporate realignment. But it's also true that even if they didn't have a since they already negotiate for the Mass Eye and Ear physicians, at least with the big three, they could stay independent, negotiate for all the rest of Mass Eye and Ear, and still generate the rate increases. Is that possible?
Could they do this through a contracting affiliation?
Yeah.
Yes, that would also be something that would be subject to HPC review as a contracting
Yeah,
affiliation.
I
but
understand
yes,
that part, but what I don't understand is, quite frankly, from my point of view, I can see the reason why they would wanna take ownership, particularly if they're gonna do some long-term investing for them. They could be doing long-term investment for them, which improves efficiency and it's good for the system. I think our main concerns perhaps ought to be what happens to the prices. And it seems to me that the prices can go up with or without that, and that's what we should be focusing on, but maybe I'm missing something.
Sure, just to clarify, the last, in addition to what you said, which I agree with completely, the very last bullet, I'd like more, because it isn't just prices, it's access. Given the more limited participation of partners in networks, this could lead to patients not being able to.
Exactly. The prices generate the lack of, although, as I was thinking, they are such a dominant player, I think the payers are gonna be obligated, not Medicaid, but if they're gonna provide those services, they are not gonna easily find a lower price substitute. So I think the more likely aspect is raising spending rather than reducing taxes. Who knows? It's like David said, there's a dynamic here that we don't completely understand.
Right, a lot of this will be dependent on the exact way that contract negotiations play out. Obviously, one of the biggest areas of access that I think many are interested in is in the mass health space, where the MCOs do have a limited amount of money that they can spend, and so there isn't the same opportunity to just kind of raise premiums if there are price increases.
You're right.
So just to pick up on Stuart's theme for a second, this is really a sort of statement that says we want cost savings but also higher prices. And the net effect seems to be about 20 million a year on the cost savings side, and then somewhere between 20 and 60 million a year on the price increase side, for a total of, say, 40 to 80 million dollars a year. So then you say, so now, and I think what the parties are saying is that money will be put to good use because it will be put to clinical services and research and so on. Now, obviously, the Secretary is entirely correct, which is it's not our job to judge whether it's appropriate for the Commonwealth to spend $40 million to $80 million a year on research and or greater expansion in this particular service area. But I guess the question, so I said that it was questions, there are two. One which has been raised a couple of times is why you need to merge to get these savings. But the second question is, if there really are savings, can't you do everything you want without lower, without raising prices. That is, if there's $20 million a year of efficiency savings, then you should be able to fund up to $20 million a year of everything, clinical care expansion, clinical facility, research, teaching, everything, and probably even still have money to give back to consumers. So I haven't like seen, there's no answer here that says, no, $20 million a year is only some percentage of what is needed to ensure access to these services, or we really need $80 million a year to ensure access to these services, or something like that. But usually we get the opposite argument, which is we're going to save money. We're not going to tell you it's going to be passed along, but we're going to save money. Here we're getting the argument, which is, yeah, we're going to save money, but we're also going to raise prices. And I don't understand why are we getting that argument? I mean, that may be the truth of what they want to do, but what is the point of why is the $20 million that's being saved not going to consumers?
I don't think we're in a position to answer that question, but certainly we'll be seeking a response from the parties and a written response.
David, welcome to healthcare in America. We've been saving money for the last 50 years only to never see it go to zero. So why is this different than any other?
I don't want to be, I don't want to be holding this up. I want to go back to the access question one more time, just I'm not sure I understand the answer. So if you look at the table of participation for 3-payer, Blue Cross, Hartford, and Tufts, Mass Pioneer is in. It's favorable in the tier networks and it's in network in limited networks. But Partners is not. It's least efficient and not in network. So if I'm a patient now and I have an Pioneer problem and this merger goes ahead, this acquisition goes ahead, sure, your argument is I still have access just to a higher price? Because I'm worried people won't be able to get the care.
Yeah, I was being dynamic in the sense that that's a possibility. I think I would have bet more likely is that the network would be obligated to provide this service.
It's that.
Networks have to provide. I mean, so I think it'll be some combination. It may be that the networks will not include them and therefore make them go longer distances, and of course, then you get into network adequacy. So I don't know. Truth is, nobody knows exactly. So your comments is a fair point. I was just saying one of the more likely options, but maybe it's some combination, is higher prices in the network, which reduces the differential between the network premium and the other premium, which is what we've seen when we talk about out-of-network pricing, which we're going to get to. But it's also possible that some of the networks will exclude them to the exclusion of adequacy.
Or that the prices go up in such a way that people low income but not Medicaid can't afford it. They would forego the care. We see that happen sometimes. I agree, we don't know, that's the point.
Yeah, I think that's, yeah, I think you're very right.
Questions or comments?
Yeah, I was going to say, that would be a good time for everyone to lay out what questions they want the parties to pose. Just coming back to
I'm not sure if this is a question for the parties to answer, but this is in the time I've been on the commission, this is the second specialty hospital that's come before us, looking for a merger. And I'm just wondering, as we move to accountable care organization models, what's the future of specialty hospitals being independent? And do we have any information from around the country where what we've seen in that market as other hospitals sort of look for cover?
In the case of Children's, they didn't. Oh, that one, yeah. So you could add Children's.
I think that's a great area of inquiry, Commissioner, and we'll look into that. I would note, you mentioned New England Baptist. Some of their concerns in joining the EI network were very similar in terms of referral patterns and the hardening of the ACO structure and what that would mean for their future. And we hear some of that from this transaction as well.
Just to use on this, because it's something that's come up in a few contexts that I've seen nationally. Most of the ACOs around the country have the view that they ought to internally provide essentially all services. And that's a really bizarre view because there are very few industries that think that their job is to provide every single service. Like, for example, Apple does not build chips, it buys chips. And automakers buy spark plugs and shock absorbers and so on. So it's a unique industry where they feel like they have to do everything internally. Whereas you could well imagine, and this came up in the discussion, them saying, you know, look, we can provide, Mass Eye and Ear can provide your otolaryngology and ophthalmology services cheaper than anyone, cheaper than you can do it. And you need the space, so just contract with us and we'll take care of it for you. And we'll be cheaper than you can do it on your own. So, but the fact that that's not happening, that is, everyone is clearly worried that that won't happen with orthopedics and otolaryngology and maybe oncology and so on, is a sort of, it's an interesting trend. To me, it suggests the market isn't, they haven't quite figured out right what their areas of expertise are and what things they don't want to do.
There, I mentioned the most, probably the most problematic specialty service, or behavioral health. Madam Chairman, Secretary, they're going both ways at the same time. I mean, at one level, we did see a very substantial carve-out industry, because in fact, the integrated systems weren't working very well. Now we're concerned about the carve-out industry isn't working very well, and there is a fair amount of consolidation going on. And you know, maybe my lifetime is greater than, well, I know it's greater than yours, David. I've seen consolidation go on. There was a time when automobile manufacturers were buying everything, Delco and windshields and stuff like that. And now they're buying automated. I wouldn't put healthcare quite so unique. The industries swing. I think it is the nature of the beast, particularly as you go to a consolidated global pricing capitation for a tendency to want to control more. And you know, you can fight it or not. I think what we're trying to do is discern what implications it has for pricing and access. And as I think we've pointed out, we can do a pretty good job on the dynamics, on the static, but we really have a hard time really totally figuring out the dynamics and how this plays out over 5 or 10 years. But some of the research suggests that when you look over time, consolidation leads to even higher prices. And we've been quite conservative in our estimates and not really imputing significantly higher long-term price increases. But I think the literature would allow you to do some of that. Fair?
That's correct. So it's important to note that as with all of our work, we sought to use the best available data to then also make pretty conservative estimates. And so all of the pricing estimates, for example, that we went over are looking at the current differentials between the price levels of the parties, whether there is additional bargaining leverage that they're able to use to exert, to see even higher prices over time is something that we did not actually get into. And so there certainly is a possibility that it could be significantly higher than what we've discussed.
Given those large numbers, it doesn't seem like inappropriate. You could just mention that without putting a dollar figure.
I think we have a footnote to that effect.
So somewhere you mentioned, although I don't see it actually in the deck, that they articulated or stated that there'd be $20 million in savings.
What they articulated is that they would have a savings in their expenditures that they would essentially knock some percent off of their annual expenditures every year by joining the partner system. We modeled what that would be, and over a few years, we're talking about being kind of the same scale as some of the price increases that we're talking about. So that was the 20 million that I cited. That said, it is cumulative, so it wouldn't be a 20 million flat, either at the beginning or at the end of this. It would, it's really about kind of a slightly different trajectory of expenses that they're projecting.
Because I thought I heard you say, I thought you actually did say 20 million, 20 million, 20 million. So it's not cumulative.
I apologize if that's kind of how it came out. That was not my intention. So over a period of a few years, it would reach the level of around 20 million a year, but it would be growing from that point on too.
So then the numbers on page would be my page 35. That's a gross number. Doesn't offset any potential savings. Like the one that says 20.8 million to 61 million annually for spending. That is an annual.
That
But
is
that's just a gross spending. It's not a net based on any sales.
correct. That is just the spending increases from price increases, and then there was additionally an expectation by the parties that they would be saving some money on the expense side, which is not reflected here.
Okay. Also, I just have, so I'm a little annoyed, so I just have to say this. So I did not appreciate reading in the State House News about this report before we started our deliberations. So the statement that's in the State House News is after this report. The statements from, so I just want to be clear about it, the statements in the report in State House News are from staff and do not reflect the deliberations of this board. And I would ask that in the future, that be timed appropriately.
So I have a question about, or I'd like some clarification on the capital investment that they discussed. So the implication, if I'm reading it, is that the Ioneer feels like they need to do some capital investment, that they have insufficient ORs or some facilities of some sort, and that they are saying that there is unused space that Partners has that they could move into. Have they, provided, have they substantiated that? This is one question. And I mean, are they really expanding beyond their capacity? Have they tried other ways of efficiencies and to utilize their own facilities more efficiently? And even if they did, how do we know that if they did combine, the Partners would eventually need to expand their facilities to accommodate them, and wouldn't that be more expensive? So I guess it's
So I think that your latter point about the question of whether Partners might need to expand later as a result is well taken, and given the scope of the services that Partners provides network-wide, it's not something that we felt that we could adequately delve into. With regard to the need for Mass Ioneer services, the parties have provided some information about the aging Massachusetts population and the rate of utilization of ophthalmology and otolaryngology services, especially by older populations, that supports their assessment that these services, additional services, will be needed in the Commonwealth. As to just where those services are needed specifically, and as I mentioned, we have no information as yet. The parties have indicated that they plan to assess where services might be expanded post-transaction. We really don't have the information to build out any assessments along those lines.
Do we have any idea what the actual acquisition cost of Mass Ioneer is by Partners? Because we're looking at 40+ million a year in revenue. There's also real estate that they're acquiring, who knows what else, but what's the acquisition cost? Have we looked at that? Because they gotta make up that acquisition cost, right? And over what period of time? How is that typically looked at in this industry?
So that is not something that we discuss in the report. Obviously, we receive the transaction documents as part of our review, but we are limited in what we can disclose given the confidentiality protections that we have in statute. So we can chat more about that confidentially if you like.
I have a question for some clarification. This gets back to the supposed savings from the efficiency or the avoidance of some capital expenditures. You say a couple times they've not committed to using the savings to reduce prices. Did they not state affirmatively what they would do with those savings? And is that a question that we would then follow up with them?
They had indicated in documents provided to the DON program that they expected that those efficiencies would be used to support that they would flow to partners as the new corporate parent, and that they would be used to support Mass Pioneer's clinical and research activities. That they would essentially be retained internally to the organization and used for operations.
And so it's not only that they haven't committed to using them as consumer savings, it's actually affirmatively stated. That's it.
Other questions or comments? So let's understand what we're talking about here. We're talking about approving a draft report. The parties would then have 30 days to make comments, review the reports. So, and then we would be asked at some point to vote on the final report. And then it would be our responsibility to, assuming that there's still some cost increases and or concerns about access, turning it over both to the Department of Public Health and to the Attorney General. Is that the orders of business?
Yes, so just as you said, the vote today is to issue the preliminary report, as you've all received. That is a public report available on our website. The parties would have up to 30 days to provide any response to it, which certainly can be factual information. They could provide commitments as part of a response as well. And then we analyze all of the material they provide or any other party provides to us, and then that gets factored into a final report. And then that would be a commission vote. We could also refer our report to other state agencies or submit it into the DON program. That is something we would do at the time of the final report. So nothing in the preliminary report speaks to that.
Can I just ask you, how do the questions that came up during this discussion get communicated to the parties? Does that get into the report, or is that in a notification to them that these are additional questions that were raised, particularly around the issues of access that were, I think, raised? How does that get communicated into this report?
We're in constant contact with the parties and certainly would follow up with them after today, and we have already offered to sit down with them and go through technical details of the report. I imagine that there might be some representatives of the parties in the room or watching on the live streaming, so hopefully they're taking good notes as well.
Just an intense question. Two questions that came up that among the many good ones. One is their determination of the effect on access through the changing in access through tiered networks and restricted networks. And the second question I have is back to the goal 1 and goal 2 of their 4. What is the rationale? Why do they need to do this in order to achieve those two aims? I'm sure there are other great questions, but those are two I'd like to see addressed.
Don, I think that the issue about access really refers as much to the payers as it does to them. And because they're the ones that are going to decide what to do with these networks, particularly the narrow or tiered networks. And to the extent you've been in contact with them, whether you want to be in contact with them again, I think it's a very legitimate issue. And it particularly is a legitimate issue for the Medicaid program. It's a very legitimate issue. Okay, any other questions or comments? If not, is there a motion to approve the preliminary report? Second? All in favor? Aye. Opposed? Abstentions? Good job, team. Thank you so much, and we look forward to seeing what changes are being proposed by the parties. Thank you so much.
Thank you.
So, moving on to the next agenda item, as the research and cost management team joins me here. We're here today to present some new analysis and some new findings related to out-of-network billing. For the past few years, the HPC has identified out-of-network billing as a priority policy issue for examination. In early 2016, we issued a policy brief specifically about out-of-network billing, and through Commissioner Cutler's Cost Trends and Market Performance Committee, held a series of listening sessions where we invited the health plans, consumers, and a range of different providers to come and testify before the committee about where these out-of-network billing issues occur, when, and what the impacts really are in terms of consumers, the availability or the viability, I should say, of limited network products, and overall market functioning. So building off of our past HPC reports and those listening sessions, we have conducted a new analysis on commercial claims data to try to deepen our understanding of out-of-network issues and where they're occurring in the Commonwealth. I would note that in conducting this claims analysis, we consulted with a number of national experts who have been looking into this issue, and really this is both a state and national conversation about how best to address out-of-network billing, and would highlight that one particular academic, Zach Cooper, consulted with us in the design of this. To our knowledge, this is the first time a state has examined its own claims data to try to understand out-of-network billing. There have been some national studies, but this will really focus on the Massachusetts data. On this slide, you can see just an executive summary of some of our key findings. I'm not going to walk through these key findings because we're going to walk through them in the presentation. And with that, I will turn it over to David Auerbach, who is our Director for Research and Cost Trends at the HPC.
Okay, thank you, David. So I'll give a little bit of background first on the topic and on our study. As you know, out-of-network billing occurs when patients receive services from providers that do not have a negotiated rate with that patient's insurer. This can happen in a number of situations. Sometimes it happens voluntarily. Patients know providers out-of-network, they go for an office visit, and they might pay that higher rate out of pocket. Sometimes it happens unknowingly to the patient. These are the situations we are more concerned with. For example, someone shows up in an emergency department, an ambulance might take them to an ED that's out of network, a physician might participate in their care that is out of network, even though they're at an in-network hospital or facility. And when there's no negotiated rate, payments to providers are based on a price that the provider might just set. There's no negotiation. That rate could be quite high. And what happens in that situation, there's a number of implications of out-of-network billing that we may be concerned with. For example, when payers pay those rates, these costs just find their way through premiums and their premiums go up. Those costs also can diminish the effectiveness of a limited network product that relies on lower rates paid to in-network providers. When you don't have that and payers pay the higher rates, the premium differentials you can get on those limited network products are eroded and they are less effective. If the payer doesn't pay that higher out-of-network rate, the patient might be stuck with a high bill, or there might be a potential balanced bill if there's still an amount on that charge. Say the payer pays most of the bill but not all of it, and sometimes the provider will charge the patient for that excess, which is called a balanced bill. So what do we know about how often this occurs or the nature of this problem nationally? As David mentioned, there's a couple of recent studies by Zach Cooper and others. One of them found that about 22% of ED visits involves an out-of-network billing. In a follow-up, more recent study in 2017, they found that there was a lot of variation by hospital. Some hospitals this happens a lot, some hospitals it doesn't happen very much at all. And it depends on some characteristics of those hospitals and sometimes whether the hospital finds that it needs to outsource its staffing. They can't get enough providers to accept in-network rates. So we see some of this variation in our own data as well that we will show you. So as David mentioned, we had some listening sessions on this topic and we really found that we didn't have a lot of data from the state in a systematic way as to how often and what's the nature of this problem here. So here's what we did. We used our all payer claims database from 2014. This was the latest year that we had so far. And we found that for a couple of the payers, we were able to identify out-of-network claims. So we identified those and we analyzed them. And we specifically chose a subset of claims that are trying to go after those involuntary situations, where, for example, in the ED. So we looked at types of claims, as you see below, emergency department, ambulance, hospital, inpatient or outpatient, ASCs, urgent care, where for the most part, these are situations where a patient might have received an out-of-network bill unknowing to them. And I'll note that all acute care hospitals in Massachusetts are in the network for these payers. So people are in the hospital, hospitals in the network, they're treated by somebody and they might get an out-of-network bill. Okay, so before we get to the data, a couple of caveats as to what you're about to see. This is the Massachusetts commercial market. The estimates here are probably representative of the nature of out-of-network bills, but the frequency is lower than you might see if we had the full state represented here, because it turns out that we have two of the larger state payers in our data who flag the out-of-network claims that we're able to analyze. These larger payers have broader networks. This is more of a problem when you have payers with small networks, that they aren't able to get as many of the providers in their networks. So that is one thing to remember as we look at the data. Even among the two payers that we have, there's a big difference in the extent of out-of-network billing. And in this data, they're combined together. Okay. So with that, I will pass. Yes.
It's just worth noting that Cooper analysis, they have one insurer, which is a national insurer.
Right.
So their estimate for Massachusetts is based off, it's a very, very small sample here in the state. So I think
exactly.
I would be very hesitant to conclude anything on the basis of their analysis of Massachusetts just because of that. Right.
Well, more than that, if you notice in the caveats, estimates of out-of-network billing for payers with national presence are much higher. So not only is it a small, but it's probably a small one that's gonna have more.
Yeah.
So that's an out of bound. So now we have.
That's right.
I would note on this point though that, and it's a little footnote here, the national health plans do account for about 25% of enrollees in Massachusetts. So there is a portion of members who would be subject to that more frequency, certainly in those areas.
And those are not reflected in the data that you're about to see. Okay. So now I'll pass this on to Rose Kerber, who is a research associate on the cost trends team, who did the work underlying this analysis.
Thank you, David. We have identified over 70,000 out-of-network professional claims from the sites of care included in our sample. These services were rendered to 30,500 unique people. As you can see in the pie chart on the left, about half of the claims that we have identified are ambulance-based. Of the portion of the claims that are for physician services not rendered in an ambulance, the vast majority are for services provided by an emergency physician, an anesthesiologist, a radiologist, or a pathologist. This too is consistent with national data. So when we combine the ambulance claims with the out-of-network claims from those four specialties, that constitutes 90% of our out-of-network sample. We will now turn to spending on out-of-network claims. We see here that for most out-of-network claims, about 2/3, the insurer actually pays the full charge amount that the provider requests. About a quarter of the out-of-network claims in our sample could have resulted in a balance bill, which David defined earlier. But the technical definition that we used was that if the charge amount listed on the claim exceeded what the insurer and the patient had paid toward that claim in terms of their official cost sharing, then we said they could have been balance billed by the provider for the remainder of the claim. Now, we cannot directly measure the extent of balance billing using claims data because we don't know for sure that a provider did in fact try to collect extra reimbursement from the patient. But there were about 10,000 people in our sample who could have received a balance bill, and if they did, the average amount they could have been billed was $355.
I've been confused about this before. I'm a slow learner on this. So you have an out-of-network provider, an ambulance or a physician, bills an amount which exceeds what the contract and the insurer normally pays. Now, if it's in-network, you see in the claims both what the payer paid and what the patient paid?
Yes. If it is in-network, there is a contractual rate, and that rate may include some patient cost sharing in the term.
And you will see that in the claim.
You see that, and we see that on out-of-network claims as
All right, so
well.
then we come to the second part, which is where I'm going, the out-of-network claim. What do you see and what don't you see?
We don't see if charges exceeded the amount spent on the claim by both the insurer and the patient through their official cost sharing that they would have had on an in-network claim. If there is an excess charge amount, we don't know if the provider actually tried to collect that amount of money.
But do you see if the insurer paid more than they would have under the contract?
Yes.
Do you see any increase in the part of the patient other than what they contract? Do you see any of that?
Not really.
Okay, so now that's what I'm getting at. So, hypothetically, a particular procedure should have cost $200. There was a 10% co-insurance, should have been $180 and $20. Instead, you see a bill for $300. You might see the insurer paying $250. You might see the patient paying $20. What's missing is $30.
Yes,
And what
precisely.
and that's what we're defining as balance billing, which may or may not get collected by the provider from the patient, but it's definitely not, and here's the, not gonna be not paid for by the insurer.
Yes.
And we do know that in some circumstances, that was absolutely right, Mr. Chairman. And we do know in some circumstances that providers may write off that amount as bad debt. So we don't, and that's why we call it a potential balance.
But what I wanted to get clear to everybody is that you do see part of what the patient paid, if it was part of the contract. What you don't see is this $30, and you don't know whether they paid it, no one paid it. But you know that it wasn't paid for by the payer.
And I would just highlight again, for most of these charges, 2/3 of these, we do see that the insurer is paying the full amount. And from a patient perspective, you may think that that's a good thing because there isn't going to be this potentiality for an excess bill. However, we do know that when insurance companies pay the full extra charges, as we're about to show you, they are far in excess of the in-network rates. That contributes to higher premiums for everybody.
Yeah, and the one thing that shocked me was a comment by the senior executive of Blue Cross that roughly 50, because we kept pushing them why they were really not giving very much benefit to people who took in-network insurance, and they said roughly 50% of the potential savings goes away by them paying these higher rates. So it's not only that it goes to everybody, it really doesn't go to everybody. It goes to the people that buy essentially network provider insurance, which is even a smaller percentage.
And I think one point to emphasize here is that certainly there are stories that occur when a patient receives an outrageous $5,000 bill through no fault of their own. And other states have put in place protections for consumers in those circumstances. But that's really just a tip of the iceberg of what this problem is. We see those big bills and they sometimes get big press stories. But what we're missing sometimes is the fact that the insurance companies, in many cases, are paying this full higher charge that, as you said, Stuart, distorts market functions and distorts the ability to put together limited network products.
So, what is the incentive for those providers to accept the network fees when they know they could get a higher fee by not being a network? Right?
Right. I mean, it's
How
often,
do we solve that problem?
we often accept that lower fee in exchange for the volume we're gonna get from that insurer. And in a lot of these cases, emergency types of positions, you're not worried about the volume. You're going to get it anyway. And the dynamic is, there's a lot of aspects of that negotiation, obviously.
So we looked at a range of procedures to identify the true differences in spending between in and out of network claims for equivalent procedures. And in our sample, we've identified $29 million total paid toward these out-of-network claims by both payers. A little over $2.2 million, or a little over $2 million could have been balance billed to patients. So the procedures that we selected were representative for both in and out of network claims, meaning that they were common in both our in and out of network sample, and they come from a variety of procedure categories. And we see some very large spending differences, and you'll notice that most of the difference is covered by the insurer for all of these categories. For a representative ambulance procedure, emergency transport with advanced life support, a typical ambulance procedure, average spending for an out-of-network claim exceeded in-network spending by 72%, including potential balance billing. For our representative evaluation and monitoring code, E&M, we chose high severity ED visits and found that with potential balance billing, out-of-network spending exceeded in-network spending by 86%. Averages are great, but they can mask ranges, and so we wanted to include something to comment on the ranges of spending for these procedures as well. These are box and whisker plots. On the left-hand side, you have a marker for the 5th percentile of spending. On the right-hand side, you have a marker for the 95th percentile. The box in the middle is divided by median spending and is marked on either edge by the 25th and 75th percentiles. So again, I want to draw your attention to the ambulance category and the E&M category because we see different ranges. So for the ambulance category, the range is incredibly large and those claims run into the $3,500 range at the high end. On the other hand, the range of out-of-network spending on our E&M procedure, which again is high severity ED visits, the range is actually narrower than the in-network range. But the most important thing to note here is that over 75% of the in-network claims for this procedure are less expensive than the least expensive out-of-network claims for the same procedure.
Can I stop you again to help me out again?
Yeah.
And I think my colleague. Let's take ambulances. I'm a patient, wake up with chest pains, call 911. Does the 911 operator say, what insurance do you have? What ambulances are in the network?
They do not.
So they send an ambulance. Well, they assume they send an ambulance. And it's a random set of which, if it's an in-network ambulance, they will charge the in-network rate.
Yes.
But and what percentage of ambulances are in-network?
In our sample, just over a quarter of the ambulance claims were
So
out.
just trying to get a picture for what could hit us all. 3/4 of the ambulances.
No, 3/4 are in-network.
Oh,
in our
3/4
sample.
are in-network. Well, that's a little nicer.
It's a little bit.
How does the in-network ambulance rate compare to the Medicare?
I do not know.
My guess is it's higher than Medicare. And they don't drive past Medicare beneficiaries. So it's not that you move the higher price and just get the ambulance to stop.
Are there Uber
It's only a matter of time.
That's an interesting question because ambulances are used for acute services, but they're also used to transport people for others who can't otherwise get places. And for those services, I just heard a talk last week that they are developing things like that for seniors to use other services like Uber to provide transportation. So the question is actually good.
And I think just to, I'm Secretary.
I was gonna say, Carol, it's for non-emergency.
Yeah, that's what I mean. All right, but this includes emergencies and non-emergencies, correct?
So this service here was emergency transport with advanced life support. We move to the next slide, we do a little bit deeper dive on ambulance, and you can see here we looked at a couple of different categories of claims. At the top, ambulance ground mileage. In the middle here, the emergency transport with advanced life support, which we had previously analyzed. And here you see, Carol, the non-emergency transport with basic life support, a differential in average claim of over 200%. But a small, relatively small number of the overall ambulance claims.
So these are the most common ambulance services. These are very basic. Ambulance rides do typically include a ground mileage claim. So even just for getting in and out of network ambulance, it is already 22% more expensive before they have even done any further procedures. So for the procedures that they do typically do in an ambulance, those differentials are even higher. We have more detail below about emergency transport with advanced life support. And you can see that most of the in-network claims pile up in the $600 to $800 range, but that the distribution for the out-of-network claims is bimodal. It's kind of all over the map. There is a peak between $1,600 and $2,000. So those are really impressive differences. And we will turn back now to ED visits. So for our three most common ED-based procedures, we found that out-of-network spending exceeded in-network spending by about 70 to 80%. And these three procedures account for over 70% of the out-of-network claims that came out of an emergency department. These are just for the evaluation and monitoring component of an ED visit, and they do not capture whatever other services the patient may also have had while they were in the ED. You can see that as the severity of the visit increases, the spending both in and out of network increases as well. For the most severe category, average in-network spending is about $330, and average out-of-network spending is about $600. Now, some states have taken measures to prevent balance billing in emergencies and have adopted other protections against out-of-network billing. And I will turn it back to David Seltz to discuss state policy.
So the final slide here, in the past two HPC cost trends reports, we have recommended state action to protect consumers and prohibit balance billing, to increase the transparency to consumers in these circumstances, and to establish a maximum reasonable reimbursement rate so that this does not result in increased spending overall. Would note, and I won't walk through the slide, that a number of states have adopted state laws specifically to address out-of-network billing. We've highlighted 3 here for you: New York, California, and Connecticut. And would note in New York, there was a study that was done after the law went into effect and found that the law had been effective in reducing incidents of out-of-network billing. With that, happy to take any further comments or questions from the commissioners on this particular topic.
Just out of interest, is there any activity among providers in the state to ameliorate this problem? It's pretty focused, and you'd think that there'd be some problem solving going on here. But I don't know if anyone did, and we the only ones looking at this.
I think it's fair to say we are not the only ones looking at this. This has certainly been a priority issue that the health plans have certainly raised over the years with us. And, you know, I would note in some circumstances, the in-network providers, the providers who are participating in these contracts, have also raised concerns about, you know, competition with the out-of-network providers who are essentially able to charge excessive amounts and what that means for the competition.
I believe the Medical Society is looking at it as well, because it's complicated. We want to make sure that people, if you're not in the network, that you somehow are able to generate some kind of a fee. But, you know, and if you join the network, it should be at the network rate. So there's a lot of interest.
I should add to this. When we conducted the listening sessions, there was unanimous support for removing the consumer from being in the middle of these situations and to prohibit balance billing. Where there is dispute is then what is a reasonable reimbursement in those circumstances, and what should the health plans be obligated to pay. And there is really the crux of the matter.
Are you sure that, I don't want to say it that way, when I read these 3 states, there seems to be only in New York any even mention of any limits imposed on an out-of-network provider with respect to what they pay, the insurance company pays. Yet I hear all the time about, well, the insurance company shouldn't pay more than Medicare rates or twice Medicare. Is that right, that there's no protection in these 3 states?
No, this is not a comprehensive summary of these states.
Because that's very important.
Each of these 3 states does have a provision for how to determine that reasonable reimbursement, and states do that different ways. And there are different models that one can choose from. New York has an arbitration process. Connecticut has, you know, it's kind of like the greater of or the lower of for different things. Our policy brief that is on our website that we issued in 2016 lays out in excruciating detail all of the different models. So, not comprehensive, would point people to that brief for a full rundown of what other states are doing.
So there is another way we can get at this. It wouldn't cover the ambulances, but it would cover the other providers. And it ties up with issues we've discussed on this commission before, and that is the idea of bundled payments. And so one way to get at, for example, the radiologist or the anesthesiologist or so on, would be to just say, just move towards a bundled payment that the insurer makes to the hospital for the emergency service to include all of the specialist services as well. So that way, there's a single amount, and then the hospital and the doctors would be responsible for dividing it up. If the hospital chose to have out-of-network EM docs practice in their facility who wanted to be paid 5 times what the salary rate would be, then that would be their choice, but it wouldn't affect the reimbursement that they got from the insurer. So, and that doesn't require a legislative solution to do that. That's just moving contracts towards a bundled amount, particularly where there's this component that you sort of hidden in there that you can't contract on, you can't make a decision over. That would still leave the issue of the of the ambulance service, for which you couldn't really feasibly bundle that with the hospital amount because the hospitals are not providing the ambulance service. But we might explore that as a way to get around the policy problem, to get around this issue of what rate do you fix, what happens if you fix the wrong rate, all of that sort of stuff.
It's certainly something we could look into. Bundled payments tend to be organized around a clinical procedure. So one could think of something around like a particular knee surgery or a hip surgery. What we're seeing
It's a visit to an emergency department, for which they already have a code. They already have a code for the facility. So the facility gets a code, and then the question is, okay, fine, let's just expand that to the professional services that were also involved in treating that particular code.
Could I just make a parking lot comment about the ambulance services? Looks a little bit like a Wild West. There's a lot of variation in prices and costs. Have we ever, as a commission, looked at the total cost of ambulance transport in the Commonwealth and how big a factor that is in over cost control?
We have not to date. This is really our first foray into this particular examination.
So, you're gonna change this, but I realize the so-called balance bill, or what the patient is obligated, is troubling, and as you pointed out, that's not the only troubling piece, and clearly, I mean, I love your charts, I love your research. I mean, that one provider, I guess, on the ambulance that's sitting out there with $3,600. Curious about them. Should I buy stock in that? I mean, what is that?
No, just you're in trouble.
And if you whack them off and just make it as illegal, and they probably have more influence than anybody else. So, on a more, this is really very helpful, and again, I think ambulances stand out as a particularly troublesome, but I don't want to lose sight of the more physician-oriented anesthesiologist, pathologist, and particularly the emergency room. Here is where you get strong opposition from a number of parties within the state. Oh, don't touch them, we should. And so this is really very helpful. Other comments or questions by the microphone? So keep at it, team. I mean, this is great stuff. And I think we're on record and strongly concerned about the need for the Commonwealth to do something here, both as a consumer-friendly piece of legislation. But I don't want to lose sight of the fact that indirectly it affects the whole concept of networks, and therefore the ability to keep overall spending. So this is not just a consumer-friendly bill. It really goes to the heart of making markets work.
Absolutely.
Okay, thank you.
Great. Thank you.
Okay, Mr. Chairman, we're going to have an update on how our care delivery certification programs are going.
The Kardashians of care. So good afternoon, Commissioners. My task is to give you a brief status report on our 2 certification programs, and then of course I'll be happy to answer your questions. So first on PCMH Prime, currently we have 107 practices participating in the program, 42 of whom have received PCMH Prime certification, another 64 on the pathway to PCMH Prime. These numbers have been holding more or less steady over the past couple of months since we last reported to you, but we do know that NCQA right now is about to conclude their reviews of a number of applications for certification. So we look forward to getting that data and hope to have some new certifications to announce in the next few weeks. Meanwhile, just a couple of other highlights on what's happening in the program. We finished our first cohort of practices that are participating in technical assistance with us at the end of September, and we're taking some lessons learned from that experience, including some great outcomes from our practice coaching and a really successful peer-to-peer knowledge sharing session that we did on NAT. And we're making a few tweaks to the design of the program and looking forward to resuming TA for practices in the next couple of months. We've also been working closely with NCQA. As you know, they reissued their PCMH recognition program guidelines updated for 2017. We've been working closely with them to align our programs, which has included some modifications to the criteria, as well as working with them to stand up their new technical platform for practices to apply.
So let me ask you that question. I know we spent a lot of time first thinking about doing this ourselves, then talking to NCQA, then paying them some extra money, given that we were expanding the criteria. How's that going? I mean, are they, are we modifying ours in any way now, maybe, or are they increasing what's going to be in their next? What's happening in that market?
Well, the NCQA 2017 PCMH program is quite substantially updated, I would say, over 2014 standards. And notably, they've adopted many of the criteria that we put forward for PCMH Prime into their program, either in spirit with minor changes or really fully identical to what we had originally in PCMH Prime. So I would say that's a positive development. For sure. They've also made, some changes to their kind of baseline medical home expectations, and where some criteria that we were using for our program align with theirs, we're just trying to make sure that our 2 sets of criteria are as closely matched as possible. So overall, I think we're in a good position with NCQA and having productive dialogue about kind of what makes a medical home and what should our core expectations be.
But I will say, Massachusetts led the nation again, because they have adopted some of the things that we already,
Right, so.
I see them.
yes, please.
And briefly on ACO certification, we're in the midst now of carefully reading and evaluating the applications that we received early in October from 15 ACOs. We hope to conclude that process and issue some certification decisions before the end of the year. And since we're in the midst of those reviews, I won't say a lot more about that process at the moment, except I do want to take the opportunity to thank the ACOs who worked very hard on these applications and put a lot of effort into working with us and submitting all this information to us. We particularly know that this fall has been an intense time for them as they look to prepare to stand up their work for Mass Health. So I just wanted to issue my thanks and look forward to continuing to work with them as we review and issue our decisions.
The universe of providers is a complete overlap with those participating in the Mass Health Leverage. There are no additional ACOs seeking certification. Notable exception of some large systems in Massachusetts, but those that are participating in Mass Health are on our docket.
So we'll finish up our reviews and then early in the next year, we look forward to starting to be able to report out to the commission on what we're learning from certification.
This is great. I mean, I remember when we were just thinking about it, the large numbers that are participating or plan to participate. Kudos. Thank you.
So good afternoon, commissioners. I have the opportunity to give you an update on some of our investment programs. Most notably, on October 16th, we had our second chart statewide convening. For this convening, we opened it up beyond the chart hospital participants to a broader group of stakeholders, which included other providers and payers and folks from various government and legislative branches. And we had over 250 participants. We had 4 different panels with our chart hospitals presenting on their lessons learned and the models that they put in place, and 8 breakout sessions, and it was a really great session. I'm going to kind of go a little more quickly because we still want to make sure we have time at the end to talk with you about our next round of investments. I love this slide. It just shows that in chart phase 2, the depth and breadth of different role types that we funded to deliver services. You'll notice that there's a lot of social workers and community health workers, and that's what's really important in making a difference in working with these vulnerable populations. I want to spend more time on results, and we've seen some phenomenal results in the CHART program. As I referenced at our statewide meeting on October 16th, we had a number of panels, and we went through and highlighted a number of CHART programs in terms of their performance to date, their staffing models, their patients served, and some of their success factors. So this is just a preview of coming attractions. We want to come back to the December commission meeting and really take a more in-depth dive on the CHART program to date. So again, I'm going to flip through these. These are just some nice quotes that we heard throughout the day that we tweeted out. One of my favorites is, CHART allowed us to shift the paradigm from talk and tell to listen and learn. This is CHART to date. So as you can see, we're coming to the end of the 2-year program, and folks are thinking about next steps. We have a number of teams that haven't spent the full amount of their award, and so we're engaging with them and offering what we're calling no-cost extension. So no additional dollars are dispersed, but if they have not spent up to their full award amount, they can continue on their program past the 24 months. Again, these are our standard chart by the numbers. You can see we've engaged in a variety of activities over the 2 years. And this is our spending to date. And then lastly, I just wanted to draw your attention to our HCII awards. If you recall, we have 20 awards in 3 different pathways: Total Cost Challenge Awards, Telemedicine Awards, and our Neonatal Abstinence Syndrome Awards. All awards are up and running, engaging and serving patients across the Commonwealth, and we look forward to providing more updates on those program successes and challenges and lessons learned. And this is just where we are in the timeline. So I realize I went through that quickly, but it was in the interest of getting to present to you on our proposal for our next round of care delivery investments. And I'll let Katie kick us off.
So before I do that, any questions on the investment program updates? I think we'll be talking a little bit more about reflections on investments in December and in just a minute.
Good, thank you.
So we are here today to give you a presentation about our proposed design for our last round of investments. We have the balance of the 2 trust funds remaining, and that is what we're proposing distributing within this design. And so I'll kick it off, and then Kathleen and Catherine will take us through the detail of this design. We're really looking forward to getting your feedback. The plan is to come back at the December board meeting with an RFR for your vote and approval, and be able to release that RFR just after the new year. As Kathleen said, there's a lot going on in care delivery transformation right now, so I wanted to set some framing about how we've been working really closely with the Mass Health team and the EHS team more broadly to make sure that our efforts are aligned, and importantly, administratively straightforward for providers to access, given all the work that ACOs and community partners and community hospitals are doing to gear up for the district program and the ACO program, which will launch next March. So this design is grounded in these particular goals and principles. The goals are what we hope to achieve, the principles are how we plan to do that work, all grounded in the triple aim and per Carol's regular encouragement, the quadruple aim, thinking about provider satisfaction and provider burnout, which we've thought quite a lot about in this particular design. So being able to bring together lessons from investments, lessons from our other broader work at the Health Policy Commission. At the hearing we heard loud and clear, continue to focus on avoidable acute care use as an indicator of system failure, and all the things that Dr. Allen mentioned in her remarks of that's an upstream indicator of system failure earlier on in the continuum. So you'll see that all of that has informed our design here. So our goals are broadly to accelerate transformation of care, and in line with other state policy efforts. Obviously there's a huge amount of work going on around the opioid epidemic, as well as increasing access to behavioral health care, both mental health and substance use disorder. Our principles are meeting providers where they are, right? So we're not trying to get everybody to a certain point, we're trying to take them from where they are and support them to be able to do innovative things, to move toward that end goal of integrated accountable care. So we work with lots of different kinds of systems and try to move them along that continuum. Also, in all of our work, encouraging partnerships. So how do we get the medical care community to partner more effectively with behavioral health care, with social services, schools, local public health, all the different partners that need to work together to improve health and health outcomes. So you'll see that play out in this design. So I'll turn it over to Kathleen, and Catherine will go through more detail.
Great, thanks Katie. So we plan to use the dollars remaining in the two trust funds to fund this next round of investments. So we have the Distrust Hospital Trust Fund and the Payment Reform Trust Fund. And between those two funds, approximately $10 million remains for additional investments. And the design proposal that we are bringing to you today for your feedback has really been informed by what we've learned through CHART and HCII. So as we looked across the $80 million and 75 awards that we've initiated to date, we really tried to take a step back and focus on the things that have worked well and that we would want to pull forward into future investment programs. So we've really learned that a parsimonious set of core measures is key, both for the providers and initiating these investment awards, as well as for us in our monitoring and oversight. We've seen through CHART that awards of all sizes can achieve measurable results. We see the importance of alignment for the awardees with the organization and the strategy of that organization, and the importance of the sponsoring organization to commit in-kind funds, especially in the context of these awardees participating in ACOs and ensuring that there is alignment between the Mass Health ACO and DSRIP funding. Across these awardees, having a preparation period has been key. You've heard us talk before, some awardees need more time than others, but offering that opportunity to gear up to engage in the work is important. And then lastly, we want to continue building the evidence base that we are garnering through CHART and our HCII awards to inform future care delivery work. Seen this slide before. The cost trends work has showed us that avoidable acute care utilization remains an issue. That's not a surprise to anyone on this commission. That patients with complex conditions have high expenditures, that we continue to see the migration of patients to AMCs and teaching hospitals for care that can be provided in the community. That providers and payers agree that in order to bend the cost curve and reduce spending, we must rein in inappropriate and avoidable acute care utilization. And that we need to continue to serve our patients with behavioral health diagnoses who tend to have higher readmission rates. So again, another slide just underscoring that, when we're talking about avoidable acute care utilization, we really want to focus on avoidable acute visits as well as and revisits as well as readmissions. And so again, some statistics because we're numbers oriented.
So two things about behavioral health and readmission, what really gets to the heart of the presentation we had at the cost trends hearings about the fact that there's real concern that the readmission analysis being done by CMS that doesn't give appropriate weight to the complexity of the patients really needs a hard look, and whether we're dealing with that at all, and particularly as it relates to behavioral.
So, yes, it's a huge issue that the payment penalty that Medicare penalizes hospitals is disproportionately affecting state and hospitals. Karen joined, Maddox shared that with us. For using it, I think it's an interesting conversation. Is that the right measure to use here? So punchline, we're proposing to use that as the sort of leading indicator of which all the care delivery innovations that we're hoping to fund and drive toward, right? So in a driver diagram, that's the last thing. Reduce your readmissions, reduce ED visits, reduce ED revisits. How you get there, we are hoping to fund a bunch of innovative models. I think it's a question of whether that's the right measure that we should be using now. We're not tying payment to it in anything, and I think that's an important difference from.
We can better understand the interconnectedness.
Yeah, and I think, there's other measurement work that we're doing with the executive office to think about measurement alignment. I think that you know about, that the secretary is leading a task force around that this has come up loud and clear multiple times, but always in the context of payment, so a payment penalty or tying it to an ACO contract. And we will definitely take those learnings and take that feedback and think about how we would construct it here. I don't think we have the ability to risk adjust a measure that we would use for an investment program, but willing to learn from it.
Katie, are you gonna keep active the learning meetings and processes among grantees?
Absolutely. And we hope to come to a future commission meeting to talk more about our learning and dissemination strategy, and we will be hitting you up.
You're on our list.
So quickly, both CHART and HCII really have placed a high value on partnership. So again, we want to just signal, and with these next round of awards, that we want to continue to support innovation in community-based healthcare delivery. And so I'm going to turn it over to Catherine to walk us through the proposed design elements.
Thanks. So I'm just going to somewhat quickly, but please pause me whenever you have questions, go through our components of this proposed design, which include the tracks or domains in which we would invest these dollars, or proposing to invest these dollars, the duration of each grant, and the maximum award size for the grants, how we would propose to measure in-kind support and encourage hospitals to come up with a strategic plan to make sure these awards are sustainable long beyond the performance period, and then the competitive factors that we're thinking about in terms of how we will weight respective applicants against each other. So to start with the two different tracks, and these are really the categories of what we're proposing to spend these dollars on. The first is to support providers to address social determinants of health that put patients at higher risk of hospitalizations or ED visits or both. We're proposing that providers would pitch to us a way that they would address social determinants after an acute stay, so an inpatient stay or an ED visit, to reduce the likelihood that that patient comes back for something that's avoidable. We would require partnership with social service providers in this situation under this track for community-based organizations for those seminars. The second domain of funding would be to support providers to reduce avoidable acute use by increasing access to real-time or walk-in type behavioral health care. This could be in a variety of forms. We're, of course, looking for providers to tell us what their innovative ideas are, but some examples would be open access scheduling, 24/7 psychiatric assessment, of course, with medical clearance as appropriate, to ensure that patients are not experiencing worse outcomes than their counterparts without behavioral health conditions. Short-term prescription stabilization and management of Most other examples in that area, it's up to 60 days for patients who are between prescribers or who have dropped off a treatment plan and are seeking to renew engagement in treatment. And or using telemedicine, mobile integrated health as appropriate. We work closely with DPH to do more thinking about what that would look like if providers wanted to go down that road. And again, anything else that was referenced to us. Partnership under this track would require, we would require partnership with outpatient behavioral health providers, or if the primary applicant was a behavioral health provider, with a medical care provider, again, to ensure that these patients have their medical needs addressed as well as their behavioral health needs. And then within this domain, we are proposing to spend some of these dollars on supporting providers in getting patients into treatment for opioid use disorder. This is connected to a statutory mandate that HPC received about a year ago to support hospitals to conduct pharmacologic treatment within the ED, specifically buprenorphine and naloxone, and then to connect patients with follow-up outpatient or inpatient, if appropriate for that patient, treatment within 72 hours, preferably less, so that the patient does not experience a gap in pharmacologic treatment, of course, after referral and based on the patient's needs and preferences, they could switch to a different form of pharmacologic treatment or decide that pharmacologic treatment is not for them and engage in other services. And again, under this sub-focus within track 2, partnership with outpatient behavioral health providers would be required for reasons that are probably obvious to all of you. For all of these tracks, we're proposing that eligible entities would include HPC certified ACOs, so that's all mass health ACOs, including provisionally certified ACOs, and their participants, so anyone within their ACO could apply and sign off on their ACO itself, and or chart eligible hospitals, some of which are in ACOs and some of which are not. I'll pause there for feedback on your thoughts on these domains and
I just have a question. So is the $3 million part of the $10 million?
Yes. And it has to go to hospitals. That $3 million has to come to the hospital trust funding.
Okay, so you really have $7 million left over for the other things?
It's up
Or-
to us to do. No, it's up to do. Not more than,
Oh, I see, not more, okay. And between funding track 1 and funding track 2, is there any sort of formula or, how did you envision dividing?
Yeah, so let me actually go to the next slide, and we can go back to the slide if you have other comments. Thank you, Dr. Allen, you led us right into the next conversation. So we're thinking about not being prescriptive from the front about caps on how much we would spend in each domain, but rather thinking about this pool of $10 million, proposing that each award would be up to $750,000. And if we got 20 applications that were very strong for track 2 or very strong for track 1 and none for the other track, we'll spend more in those tracks. That's what we're thinking right now. But again, all of this is open for your feedback.
2 other comments I'll just make before getting into other questions. One is we have decided we'd like to fund evidence-based interventions. And this was the topic at an event that Marty and I and some others were at that the Blue Cross Foundation had yesterday. Is the provider community saying, why limit yourself to just funding evidence-based things, funder? You should be funding innovation more broadly. I think with the amount of money that we have, and given that this is the last pool of money that we have in the trust funds, we as a staff feel strongly about keeping that commitment to evidence-based interventions. It can be evidence-based somewhere outside of Massachusetts, not done in your provider, so that's just one thing I'll note. And the comment on restricting it to HPC certified ACOs and their participants is really one of sustainability, right? So if we give you $750,000 in funding and you put forth $250,000 as $1 million project, we want to be pretty sure that that work can be sustained. And so you would need to have a payment mechanism and a financial structure in place that would potentially sustain that. And we just don't have that assurances if you're not in an ACO today. So that's our thinking around limiting it.
Why the limit of 750 per track?
interested in your feedback. That is what we used for HCII. It seemed to work pretty well. Everyone proposes up to the gap. So I think there's quite a bit of math that happens there, but it just allows us to fund more. And I know you have made a comment at the committee meeting of why not put more money into fewer systems so that you could make a bigger impact. And we've debated that a lot, honestly, so I'm interested in the commission's feedback on that particular question.
Your answer to that question was, you haven't noticed any difference in the ability to meet the objectives of bigger projects versus smaller projects. So therefore, we concluded that smaller projects work just fine. Is that accurate?
Yeah, and especially given that we hope that this is sustained after the program ends. It is, I think, harder to sustain larger dollar projects than potentially smaller dollar that could make a similar impact.
Just a question on the eligible entities include HPC certified ACOs and their participants. Is their participants limited to the designated community partner, or is that now?
So
Short answer, no.
yeah, I think, but this is also a point of debate that we've discussed, is do we make community partners in the Mass Health definition of community partners? For those of you that don't know, they're the providers that will be providing services to the SMI population and to the LTSS populations. And so they aren't ACO participants per se, but they will obviously be working with ACOs. Do we make them eligible for this? Our strong proposal on that is with the limited funding that we have, and given that the ACOs are receiving the reform payment, not the CPs, that we would limit it in that way, but really open to feedback from folks on that. We've talked to a bunch of providers and heard differing perspectives on this.
Can I just urge a little gentleness on the evidence-based thing? I think we talked about this. I mean, we've got a lot of creativity in the state, and if someone shows up with a proposal that's pretty exciting and the logic model is strong, we may be the first to do something, and I wouldn't walk away from that. I think you got the ability to spot something that's promising, even if no one's yet done that yet.
Well, again, this whole area of our chart programs and how we've invested in it, the kind of changes that are being made are really impressive. And it was kind of it wasn't a sleeper because it was a lot of money, but over time, I think it's proven its worth. And as I said in the cost trends hearing, in a kind of an indirect way, it was one of the ways that we've helped the low end of our delivery system in terms of the ones that get the lower prices sort of survive and get better in a way by taking from the top, reinvesting it, and doing it in a very constructive way. So I think I speak for my fellow commissioners. The amount of work that your staff has done is really impressive. So thank you so much.
Thank you.
Okay. So I'll just quickly go through, we have a few other things for your consideration, but if there are no comments, we're fine. So as I mentioned earlier, we would require in-kind contributions from either the parent entity or the applicant itself, such that, as Katie alluded to, that would bring up the award if they applied for the full amount up to $1 million if they're putting in 25%. And again, we propose to require very strong sustainability plans to encourage applicants or require applicants to demonstrate to us that they have a plan in place to continue any effective innovative model that is going well during the performance period. And then finally, these are our competitive factors that we're proposing using to compare applicants to each other with respect to relative strength of their proposal, and look forward to your feedback with respect to how each of these should be weighted. As most of you probably know, in procurement we tend to weight certain domains more heavily than others. So the first domain, proposed domain, would be the care model itself and the proposed impact that the provider thinks it would have on the community in terms of health and expenditures. The strength of the evidence base, but again, appreciate your feedback that maybe that is not something we should put too many points on. A strong multidisciplinary team, of course, because we're addressing behavioral health and social determinants here. That's critical, as we've seen in past awards. and the role of the relationship with that required community partner, be it a social service entity or a behavioral health provider, proposing that an application would be more competitive if the applicant was proposing to pass through award dollars to that entity, but not requiring them to do that. Second domain would be looking at the leadership and organization of the entity, of course, what their organizational strategy is, how aligned they seem or in touch with their ACO's population health management department, and whether or not this initiative noticed by that PHM department and its successful scale across the ACO. As always, the financial health and financial need of the organization, any past performance in any of our awards that that entity has received or is currently monitoring, and then the strength of and the capacity of the leadership to engage in this project, including the amount of time out of their week they spend supervising the project. Again, we've talked about sustainability and scalability quite a bit, so I won't harp on that, but just want to note that we would propose that strong alignment with whatever district dollars and the way they propose to spend those dollars would be important to us in evaluating these proposals. And then to continue to build that evidence base, especially if it's a model that doesn't have a strong evidence base, we would want the applicants to show us that they have a plan to evaluate their program in a somewhat robust way, recognizing that evaluation is something that many of these providers don't have a lot of capacity to do. But that's
So any thoughts about relative weight here? We heard Dr. Berwick's thought about maybe relaxing the recommendation around evidence base, but any of the rest of these seem particularly more important or less important to you all?
Can I just raise a factor that I think we should consider in adding to this conversation? I agree with the presentation and great work, particularly around the tracks in which we want to fund, but one of the things that I've raised around these issues, and when we have grantees coming and talking about the success that they had, it's really about engaging the workforce in the process, and not just, here's a project we want to do and go do the project, but really both innovative and evidence-based, that through innovative labor management partnerships where workers are at the seat of the table helping to design the plans, have engagement in that, we have much more success. And I'm wondering, I see a lot of talk of partnership and engagement with varying levels of leadership within the organization or community partners, all makes a lot of sense. Just wondering where we could fit or see the role of the frontline caregivers in the development of these programs and plans, and how do we score that or add that as a competitive factor for some of these applications?
Yeah, I think the same could be said for patients and families, right? So I think when we look at the project leadership and the project governance, stronger projects would be ones that directly have patients and families and the frontline workforce at the table. And Kathleen can speak much more clearly about this than I can, but the successful chart programs have had that. And the ones that sort of came from the top down, not as much so. So we can certainly play that out a little bit in the development of the RFR. That's a great idea.
Any other comments? Again, I said before, great work, and we look forward to keeping us informed.
Thank you very much.
Okay, so we're reaching the end of the time. I just want to recognize that we have an upcoming meeting in December, on December 12th. And as David pointed out in the beginning, he's given us a preliminary schedule for 2018, so let me just get any comments, questions anybody wants to bring up before we adjourn? You all set? David, you all set? Thank you again for a great meeting. Thanks a lot. Take care.